Good afternoon to all EUPSA members in Europe, and good morning for those in the West, and good evening for those in the East. On behalf of the EUPSA Educational Committee, I would like to thank, first of all, Ms. Gaia Tamaro, EUPSA Administrator, for the perfect organization of this webinar, and our two guest speakers, Professor Ramnath Subramaniam, Consultant Pediatric Urologist in Leeds, United Kingdom, and Professor in Pediatric Urology affiliated to the University of Leeds and Ghent, and Professor Mohan Gundeti, Professor of Pediatric Urology Pediatrics at University of Chicago, USA, who are two internationally recognized leaders in the field of pediatric robotics and laparoscopic surgery. So we can start this webinar with the first talk. The first talk will be by Professor Ramnath Subramaniam, and it will be on basics of robotic surgery. Thank you, Ram. Yes.
Thank you. So officially, thank you very much, Sal. Thank you, Gaia. Thank you, EUPSA, for inviting us. And Mohan and I go a long way working together. And we are privileged to be part of the faculty pushing robotics beyond the boundaries that is actually meant for. And you'll understand what I mean in the next few slides. So this is a word that I like to share. When you go to Google, if you look proselytism, it basically says it's an act of attempting to convert people to another opinion. Now, basically, it is a religious connotation, but we will set religion aside here and talk in the context of robotics. And this slide was given to me like 25, 30 years ago by somebody, so you can see how futuristic the slide is that someday robots would come and try and replace clumsy human hands. I dare not say clumsy, but that's the whole connotation of proselytism. So as we well know, robotic surgery is well established in urology, and it's got significant benefits in prostatectomy. But pediatrics is unique when it comes to robotics. And the current robot was not developed for adults, was developed for adults and not children. And there are challenges when you come to use it in children, not least the trocar, insertion of trocar and the instruments. Sorry, there's something else coming up here. Yeah, okay. So when you come to a theater setup, in terms of adult surgery, because 85% of the robotic cases are prostatectomies, the theater standard is standardized for every case. And there are routine tasks for theater teams with increased efficiency. When it comes to pediatrics, if you want a robot in a children's hospital, it's more of a multi-specialty involvement. Therefore, we need to understand the entire orientation of theaters better than the adult team needs to do. Because we have more than one case, and if you have more than one case, the theater setup changes, especially if pediatric surgeons and urologists and everybody is using it. And that is why this term SAC is important. You need to know where your scope is, you need to know where the anatomy, which means where the patient, what you're looking at, and you need to know the cart. And all of them should be aligned against it. So from the scope to where you're looking at target organs to the cart, it's quite useful for all three to be aligned. This is some basics of laparoscopy. We know that the relative size of the pediatric abdomen, and because there's diaphragmatic breathing and the insufflation pressures is too high, can affect the tidal volume. The other problem we have is that if there's a gas leak, there is rapid desufflation, and a small space is an hazard, because if there was something to go wrong, there is very little time to actually react and to come over. That's why pediatric robotics is far more challenging. The other thing we need to understand is port placements, especially when you're using this approach in children. And another big bugbear is, as I explained to you all earlier, the instruments are not made for children, but for adults. The so-called 5mm instruments actually need more space to recognize their endo-risk capabilities. And this is because the 8mm instruments are cable driven in technology, and they are more diverse. And also it allows the use for energy devices like bipolar, diathermy, or plasma kinetic gyrus, which I like to use. The 5mm instruments are less diverse. They got solid metal working ends, and they do not have the capability to have instruments like bipolar energy devices. Now, when you see adults, just because of the size, you can see how the ports can be easily placed, and you can place lots of ports. Now, Intuitive Surgical, when they recommend, they will tell you that there needs to be at least 8 to 10 centimeters distance of the instrument from the camera port, and it needs to be 5 degrees beyond the camera port. Now, that's changed with the recent robots, but still, there is very little room in children to have a large assistance port. And in adults, you can use a third arm, whereas in pediatrics, I have hardly ever used a third arm. And in fact, I only have a 3-arm robot, which means 1 camera and 2 arms for working instruments. So you can see in children, the close placements can be a real asset because of clashes. And therefore, we need to have more interaction with the entire team. And as I said to you earlier, there is really no need for a third robotic arm. So we need to adapt and use some consoles, some solutions. Like in the consoles, you need to have more wrist movement. So avoid those laparoscopic movements. You need to keep the instruments that you're using right in the center of the screen at all times. The role of the first assistant and the scrub staff are also extremely important. And their role is to keep the surgeon, who's at the console, informed of the patient safety at all times. And they need to communicate that needles is coming through the robotic ports because I use just 2 ports, so they have to switch and keep doing that. It's very important for a robotic program to be successful for team working. Not least, at least you can blame someone else if something goes wrong. So, but and just jokes apart, it's quite important that team working is recognized. I'm just going to show you how we've adapted this video, the role of first assistant, so that we can actually be more efficient when we are working. So the first assistant here is changing the 8mm to a 5mm by putting the cap on. He's sending me the needle through the port. And you can see in the inset, when he gives me the port and takes the other needle away. And this is how we prevent using a third arm for instrument exchanges. But the first assistant is communicating with me at all times and is really swift and efficient. See, he communicates with me and he says he's ready. Sorry. So we've seen that picture. Now I just want to introduce you a concept of side docking. This picture here shows that the patient in lithotomy position with the robot coming in between. Whereas when we use what we call as side docking in children particularly, is great initiative to use side docking, because then you don't have to put such exaggerated positions in lithotomy, etc. For all my patients, including reimplants, bladder reconstructive surgery, pyeloplasties, nephrectomy, name it, I try and use a lot of side docking. For pyeloplasty, of course, I can't on nephrectomy. That will come from the side of the affected kidney. But for all the pelvic work, I don't put them in lithotomy. I do them on side docking. This is something really special, and it works very well in children. So at that point, we disregard all the principles of keeping the arms aligned with the cart, and we move everything onto the lateral aspect. And because the children are quite small in size, you can easily reach to them by keeping the robot on the side. So the usual procedures that we would do, especially when you're on your initial learning curve, would be pyeloplasties, nephrectomy or nephrouretrectomies, and heminephrouretrectomy. If you want to move So this is a patient where a pyeloplasty, and you can see the crossing vessels here beautifully demonstrated here. But I will not go into details because Mohan will be talking about it in a minute. But you can see how nicely you can approach the kidney. And I always put them in a supine position with a little bit of wedge, just to allow them to be raised up on the one side. And I do not necessarily put in lateral positions. When you advance in your training, and Mohan will talk about it later, then you proceed to do reimplantations, Mitrofanovs, auto-augmentation, etc. That's one picture showing the catheterizable channel. And this is detrusorotomy, where you can see the mucosa has been exposed to create a bulge. So-called auto-augmentation procedure, which is much more in vogue now, and keeping with my research interest of using less bowel in the urinary tract. The most important thing is education and training. And I have teamed up with Orsi in Belgium, where I have console experience and training on porcine models. And it's great for people who are starting off their training program. And there are various training opportunities which are on the website if you would like to be informed of them. Thank you.
Question would be in terms of the robot, do you share with somebody, or it's just for the pediatric department, or do you share with other specialty and the cost and everything in your department? How do you, how is a robot basically, how is managed, the whole thing in terms of maintenance, and who buys it?
So in Leeds, we have a children's hospital. We have our own robot. So it's basically managed by the pediatric surgeons and urologists, and we got a combined program going. So I mean, as Mohan said, it's all about business cases. You need to do at least about 125 to 150 procedures a year to break even, and the management to feel comfortable that they'll invest in a program for you. But if you're an adult, I mean, when we first started, we were an adult team, and like Mohan says, you need to then find out where is your block of theaters and timing to use the robot. But in Children's Hospital, luckily, we have it for every 5 days, 6 days a week, the entire week, so we can manage it. But you need to be innovative, and just by doing pyeloplasties and nephrectomies, you're never going to put the benefit. And how I did it was by doing Mitrofanovs, detrusorotomies in spina bifida patients. I did cost analysis, and I showed that by reducing the bed days in the United Kingdom, at least in our healthcare, each bed day is nearly 300 pounds. My patients were going on an average 2 to 3 days home compared to 5-7 days when they had open surgery with phalanstery incision in spina bifida population, as you can imagine. And I showed that in the first 20 cases, we saved nearly 20,000 pounds. So you have to be smart, you have to be effective, you have to play it on their own game. Do you understand? You need to understand your healthcare, and that is a fundamental challenge. What Mohan has got challenges in the United States is very different from challenges that I have in UK, very different from what you have in Europe. But effectively, it's all being reactive, smart, and be one ahead of the game to convince the management that you're worth investing in it. And your patients are the best advocate. As much as you can get compliments, feedback, it helps a lot. So it depends, but generally it's just being determined and believing in the technique. For example, there are centers, I mean, we are the main center in the UK. In other centers, they're not even doing much because it's the vision, it's the leadership to take it to a different level, and you need to prove that to people. And then, so yeah, it's like that. Mohan and I have a similar personality. He's more soft-spoken than I am, but I'm generally, we are both determined people. and you need that personality to drive things forward.
True. Mohan, what's the robot in your department? Is only yours, or you share with other specialty, or?
No, I don't have that liberty. I have to share. So what we have is we have a university's robotic program, and we have 4 robots in clinical operation. 1 is a single port and 3 are XI. And what we did is all our hospital are connected to each other. So children's hospital, adult hospital, and they're like, probably 100 feet different each other. So we installed all the systems in the new operating rooms, which is our adult OR complex. So we have 4 robotic rooms there, and we allocated the time for each specialty every day. And that's how we've been very productive, because, I'm the only pediatric urologist and pediatric specialty using it, and it won't be that viable. So that, it's better that 4 of all using specialties is everyday use. And then we have one in the laboratory for training and, helping all the junior surgeons to learn on this. So that's how we operate the whole robotic program.
Very good. Very, very interesting. Now, I have another question on so always the approach is via transperitoneal approach. Am I right? All the procedure, most of pyeloplasty, nephrectomy, heminephrectomy. Am I correct in saying that with a robot, you always go transperitoneal, or you also have the retroperitoneal route as well? To both of you, please.
The vast majority of people do it transperitoneal, even with laparoscopy or robotics, only because training is easy. For some people, retroperitoneal is very, very difficult. I did retroperitoneal laparoscopy, retroperitoneoscopic procedures before robot, and I also tried them when the robot came along. And although it is feasible, it's really, really challenging, and you cannot really train the people up that easily. So that's where I gave up, and I do transperitoneal for robotics. But I know that there are some people who are still trying to do retroperitoneoscopic surgery, particularly Thomas Blanc in France, in Paris, he's doing, because he was a disciple of Alain Gonemi. So they follow that trend of trying to do retroperitoneoscopic. But vast majority of people do it transperitoneal, I think. I know, Mohan, how you feel about it.
No, I agree with what you said. I think, mainly transperitoneal, and some are trying to approach retroperitoneal, as Ram mentioned. And adult urologists are also trying to get into retroperitoneum now to see if the renal surgeries will be helpful. So that will be something to look after in the future, and may have to compare transperitoneal and retroperitoneal, again, how we did it in the laparoscopic era. So that will be the future food for thought.
Thank you again, both of you. Now, I'm just going through the question. What is the lowest age, weight of the child that could tolerate robotic surgery? So again,
I don't think there's any low age weight where a child can tolerate. It is interesting story during my experience. Initially, because I wanted to keep it safe, especially when I'm away from the department, I said we can only do under 1 year of age, 1 year or above. And 10 kilograms was the weight of leptin. The lockdown, interestingly, made me use the air seal device now for patients, because they wanted to use as a filter and prevent smoke coming out of the doing these minimally invasive procedures. As you can imagine, there's a lot of hoo-ha about it. And what I noticed with the air seal, that you can reduce the pressures to nearly 50%. So previously I was doing 10 and 12 millimeters of pressure. Now I'm doing 5 and 6. And that has brought ability to bring even smaller child in. So now I am happy to relax it in the department. So although there is no set age limit, yes, you have to be careful, but it can be reduced down considerably, provided you have the right equipment with you.
So I agree. I think the air seal is really important, and slowly you need to move on to, decrease the age and the weight of the surgery. It needs a lot of, some small adjustment, and slowly I moved down to, 5 kg, 6 kg, and the youngest one was like a 3.5 kg. And some of the intricacies involved, we talked about, you may have to take into account. Now, rather than just the weight, what I noticed as I was doing more and more infants, the abdominal surface area, that determines a lot. And there are some different races, ethnicities, which have very small scaphoid abdomen with a small space. And even though they have weight like, 3.54 kg, the surface is very low, it gets very difficult. But there are some, ethnicities and different varieties, people who have, large abdominal surface area, and their weight may be just 3.5 kg, and it is much more easy to do that. I didn't come up with any objective assessment yet, but, again, we could go slowly lower down, but be careful that, be, careful and cognizant. Don't jump onto that, okay, all right, somebody did 4 kg, I will do 4 kg. No, go slowly and be safe.
Okay, another question is about the transmesocollic approach for pylorothotomy. You know, if you have a big stone in the pelvis, you're going to do a robotic pylorothotomy. Do you go transmesocollic or the standard way?
As a rule, vast majority of the left pyeloplasties, I do transmesocollic.
All right, okay.
Because it's much easier. You see a pelvis sitting down there. On the right-hand side, it's different. You can do transmesocollic. So I don't think whether it's transmesocollic or retrocolic really matters. I think what matters is good exposure and be able to drive your camera through into some of the calyces if necessary to look for these stones and retrieve them. But yeah.
Mohan?
Yeah, I agree with the same. Nothing
Okay.
changed.
Now another question is, how viable is doing a hidden incision robotic pyeloplasty in children where all ports can be placed below the belt line?
Don't know, never tried it in the robot, so it's not something that I can answer.
I think there's some colleagues have tried here in United States. I don't have personal experience with either.
I think it's done. I think we've done no more questions. You know, can I remind everybody that the video of this webinar will be edited on the web, will be edited and will be available on the EUPSA website and the EUPSA YouTube channel. So, and loads of people tend to review the webinar afterwards in the YouTube channel. So just not for all the attendee here who came late, and for everybody else, it gets edited and it will be on the EUPSA YouTube channel. I would like to thank you again on the behalf of the EUPSA Education Committee, our two exceptional guest speakers. It's been a very, very interesting, fascinating talk, you know, on the pyeloplasty, pyeloplasty, and setting up the system, you know, the robotic training system into a hospital, especially for people who don't have the robot, and fascinating talk. Thank you again, Ram, and thank you, Mohan. And thanks, Gaia, for the perfect organization. And on behalf of EUPSA, again, I wish you stay safe to everybody, and thanks again.
Thank you, everybody. Thanks a lot.
Thank you very much for being with us.
Thank you, Ram. Thanks,
Thank you.
Salva. Thanks, Gaia. Thank you, team.